Hey everyone, and welcome. We're jumping right into a quick 5-minute clinical briefing designed for you, the pharmacist. Today, we're going to sharpen our patient counseling skills for STIs and arm you with the key points you need for those conversations at the counter. Let's dive in. So, first, why is this so important right now? Well, the context is pretty stark. STI rates are climbing across Canada. And this isn't just a statistic. It puts us as pharmacists square on the front line of public health. Our role has just never been more critical. That brings us to the big question for today's explainer. What are our key responsibilities here? We're going to tackle that by breaking down the most common STIs, their go-to treatments, those crucial side effects, and, of course, the practical counseling tips that really truly make a difference for your patients. Okay, let's start with a scenario you'll definitely see. A patient comes in describing symptoms of abnormal discharge. The very first step to good counseling is knowing how to differentiate the potential causes. This little table is your cheat sheet. You'll notice right away that pH is a major clue. If it's below 4.5, you're probably looking at candidiasis. But if it's above 4.5, your mind should go to trichomoniasis or bacterial vaginosis. From there, you just look at the discharge itself. Is it clumpy, frothy, or more milky? These are really powerful clues. Now, here is an absolutely critical counseling point. Metronidazole can be used for both BV and trichomoniasis, but the advice you give is totally different. For bacterial vaginosis, you only treat the patient. But for trichomoniasis, it is essential that their current sexual partners also get treated. Otherwise, they'll just get reinfected. And speaking of metronidazole, this is the #1 non-negotiable warning. You have to tell patients to avoid all alcohol during treatment and for at least a full day, 24 hours after their last dose. That disulfiram-like reaction is no joke. It's a huge patient safety point. All right, let's move on to another super common one, uncomplicated chlamydia. According to Canadian guidelines, the preferred first-line treatment is a simple 7-day course of doxycycline. So, when you're dispensing that doxycycline, here's your mental checklist. You've got to warn them about photosensitivity, so wear sunscreen. Advise taking it with food to help with any stomach upset. And please stress that they must finish the entire 7-day course. Also, remind them no sex for a week after starting therapy, and all partners from the last 60 days need to get tested and treated. Now here's a fantastic clinical pearl. While azithromycin is sometimes used, studies have shown that doxycycline actually has a much higher cure rate for rectal chlamydia. This is a really vital piece of information, especially when you're counseling men who have sex with men, as rectal infections can be more common in that population. For gonorrhea, the whole game is about fighting resistance, so the strategy is combination therapy. The go-to regimen is a single shot of ceftriaxone plus a single oral dose of azithromycin. You're hitting it with 2 different drugs, and that's our best shot at knocking it out for good. Okay, let's switch gears to another common presentation, genital lesions. We're going to focus on the key counseling points for syphilis and HPV. The gold standard for syphilis is benzathine penicillin G. But, and this is a big but, the dosing is totally dependent on the stage of the infection. For early-stage syphilis, it's just 1 dose. But for latent syphilis, or if you don't know the duration, it's a weekly dose for 3 straight weeks. That's a huge difference. When you dispense penicillin for syphilis, you need to give your patient a heads up about the Jarisch-Herxheimer reaction. They might get a fever, chills, or a headache within about 24 hours. You have to reassure them this is just their body's inflammatory response to the treatment. It is not a penicillin allergy, and it'll resolve on its own. Now, for anogenital warts from HPV, a common first-line option is a mimiquid cream, which the patient applies themselves. This puts us, the pharmacists, in a key spot to counsel them on how to actually use it correctly. 3 times a week, wash it off after 6 to 10 hours, and how to manage the skin reactions that are pretty common. Okay, so we've covered a bunch of specifics for different infections, but let's zoom out for a second. There are some universal principles that really form the core of our counseling, no matter what the diagnosis is. Partner management. This is the absolute cornerstone of stopping the spread. Think of this as your quick reference. For chlamydia and gonorrhea, we're talking partners from the last 60 days. For primary syphilis, it's 3 months. And like we said, it's current partners for trich, but no partner treatment is needed for BV or a yeast infection. And here are the behavioral tips that apply to pretty much everyone. Advise no sexual contact for a full week after starting treatment. This gives the medicine time to work. Always talk about correct and consistent condom use. And this is a big one. Because reinfection rates are so high, recommend they get screened again in 6 months if they were treated for chlamydia or gonorrhea. All right, to wrap things up, let's just quickly touch on 2 areas where our advice is so valuable: managing STIs during pregnancy and the powerful prevention tools we have at our disposal. This is just a high-level safety summary for you. The big takeaway is that drugs like doxycycline and the fluoroquinolones are generally a no-go in pregnancy. The safer preferred options often include azithromycin, penicillin, and ceftriaxone. You should always double-check, of course, but this is a great starting point to have in your head. And we're going to finish on the most powerful note of all: prevention. As pharmacists, we can really champion these tools. We can remind eligible patients about the HPV vaccine, which protects against both warts and cancers. We can encourage Hep B vaccination, and we can always reinforce that message of consistent condom use and regular screening. So I'll just leave you with this question to think about. How can you take these key points, from differentiating discharge to remembering those partner look-back periods to promoting vaccines, and make STI counseling a confident, routine, and really impactful part of your daily practice?